in situ simulation versus simulation center simulation. I do work with different capacities with those people, but as I said yesterday, nobody pays me any cent to say what I will gonna say. All the work that I'm presenting here comes from the team from Clinical Skills Center in Jeddah. We do have many activities, especially assessments. In situ, most of our simulation is in the simulation center. Recently, we moved out to do some simulation activities in the hospital, but we do have a lot of off-site simulation activities, all type of courses. So what is simulation, in situ simulation? It's any simulation that is being done at the workplace. It's out of a dedicated center, and it has many key features. And actually, I have to admit, preparing for this talk has been very educational to me, in addition to the different options that are there that we could utilize. Just to sum it, I will be talking about the rationale, uses, pros and cons, variation of in situ simulation, how to optimize it, and to summarize. Just to, if you want to have this in a clip, I hope the sound will be on.
And nobody paid any attention.
This summarizes everything about in situ simulation.
People learn in lots of different ways, but experience is the best teacher. Today, smoking is going to save lives.
Oh my God! Oh my God!
Fire! Oh, fire! Oh my goodness! What's the procedure? What do we do, people?
The bones are dead.
Oh, how did that happen? Oh my God! Okay, it's happening. Everybody stay calm. What's the procedure, everyone? What's the procedure? Stay calm! Wait. Everybody calm down! No! Anyone? 911. This has been a test of our emergency preparedness. There is no fire. It was only a simulation.
What?
Fire, not real. This was merely a training exercise. So, what have we learned?
So, if you want a summary of advantages, disadvantages of simulation, that clip give it to you. In situ simulation, you could actually use any type of simulation: mannequin-based, simulated based, task trainers, hybrid simulation, actors, any type of fidelity. You could just do it scheduled on a regular basis like mock code or impromptu. If you want to test the system, you could just run simulation to see whether the system is ready. You will use authentic teams, so you won't assign people to different roles than what they do in real life, and that has many advantages. We know that simulation-based learning is widely accepted and very safe. It's supported by a lot of theories like experiential learning and system engineering, in which you could integrate 5 important components. That's persons, tools, technology, task, physical environments, and organizational structure. So you could test everything when you do good in situ simulation. And you could, if you introduce changes in the workplace, you could always test it with in situ simulation. This is a few slides that I added based on the discussion we had yesterday, the role of experience in learning and how we learn, and the talks, the suggestions that Dr. Muhammad made yesterday, changing the mental map and processes inside. And this is a very well-known theory for education, that experiential learning. So we have an experience, then we have a reflection, and that's when reflection we could look at what we are doing and then have some concepts and go through another experimentation to go through the learning process. How did we do in this first time, and then how did we improve the next time we have this? And this is what we always think about. In simulation, like in real life, we use reflection to help people think in action the next time, to collect their thoughts, have a plan. And the most important thing, to reflect on action, to think after what they did in the past, how they could improve it in the future and change their mental. So that's the process of reflection and how we could change the mental plan or have a better algorithm in our mind. So that's to build a conscious awareness of our reactions and reflection to the critical situation or experiences. And this is actually how clinicians acquire, and this is the way that going through this cycle, we move from being novice, beginners, competent, proficient, expert. It is just going through these cycles. And if you want a very good examples, you know, like we have a reaction. If reaction followed by good reflection, that will result in learning. And the most important, if that ingrained in us as behaviors, that usually will evolve in the second time as results, because we will change our behavior. The first time we panic and we froze, the next time said, I will not panic, I'll pause and think, and I see where I am. I will develop or look at the big picture, develop that. And the more you go through this, the more you have experience that you could prepare yourself for emergencies and rare things. The role or the relationship between experience and confidence. A lot of people think that the more experience you have, the more confidence you will have. But we know that's not true. People go through this. First of all, they have little knowledge. You know, like if anaphylaxis happen, I'll just give adrenaline. Or fiber optics is very easy. But the first time, when they try it, they will have that dip in confidence. Then when they practice more, and these stages, we go through it. First, it's unconsciously incompetent. You don't know, but you don't know that you don't know. It's لا يعلم ولا يعلم أنه لا يعلم. Once you go through first experience, you create the awareness. Then you become consciously incompetent. Now I don't know how to do that. Now I need to learn to practice. Once you do more learning, now consciously competent. I could just do it. You know, like today I'll go and do an epidural. I will stick the needle. You think about it. I will drive the car. Once you do it more, you become unconsciously competent. You just do it. You don't think about it. That's stage number 4. That's come with deliberate practice. The good question is, can people go from 4 to 1? Especially for rare events? Or can people go from 4 to 1? If you cycle, can you lose cycling? If you swim, can you lose swimming abilities? Actually, those are the 2 exceptions to that rule. If you don't have repeated experiences, you will be rusty, or if you're not interested, or very rare. And that's very common for a lot of things that we have in medicine. These are very rare. So everybody will be incompetent with time unless repeated experiences happen. So that's just something that we always talk about in education and simulation. This is, if you want a good example of this curve, how it goes upward. It's stethoscope, you know, like novice medical students. Here when we grade for medical school, if you continue to be a cardiologist, you will go in this curve. You will just continue to go up. If you go to plastic, I think you will, or orthopedic, you will go other way direction. So this is, has been shown repeatedly. So this is the deliberate practice that you go through conscious reflection, and that's what make progression either to be competent, and that's what they do in aviation. Through simulation in Situ and in the simulation center, they go through that deliberate practice, tasked with well-defined goal, motivation to improve, feedback, opportunity for repetitive practice and gradual refinements of performance. And that's how we could get competent even in the rare situations. This is just to give you an example of the use of in situ simulation. We had an introduction of a new surface, total or pediatric cardiac patients, total body irradiation. We had cooperation from different hospital, from specialist hospital, University Hospital, anesthesia, radiology, chemo team. Everybody was dealing with pediatric patients, giving anesthetic in a remote area, new suites. So we gathered everybody for in situ simulation. So we simulated the whole experience. That's weeks before the event. People went through the whole using the mannequin to most age-appropriate mannequin, went through the intubation, positioning, calculation of the dosage, and everybody was nervous to start with, but once this is done, once and twice, everybody had time to reflect, repeat the experiment till everybody is confident, and the first case done, it was like just routine. You could not just differentiate with this is a simulated case or this is a real case. So that was a good example of, so the uses for in situ simulation, most of the team to improve team performance. The most important also to identify and mitigate threats to patient safety and improve protocol systems and infrastructures. This is the example I talked yesterday about Ebola and Corona preparation in our hospital. We first run a drill through ER, ICU, and wards to see what the teams would do if there's a suspected Corona with the relatives, with the whole protocol. Then we developed the training and then conducted the training in our hospital for Ministry of Health for the Hajj. So I'll just briefly talk about the advantages, disadvantages, and safety issues with simulation. So advantages, of course, you will allow people to practice in their own area. Everybody comfortable in their area. It's the realistic environment. Less detail for debriefing, so because you don't need to tell them this is this and that. So they know the environment. Easier and more accessible, no need for expensive dedicated space. So you just use the existing space. If families are around and they see you that you do simulation, they will trust the system more. You don't need to charge anybody because it's free. And it will give you hints about your local problems. And you could tailor the simulation to whatever you have at the place and to introduce guidelines and protocol and improve your actual teams. Easy to follow up, you could just repeat if you need repeated scenarios. And you could use any place in the hospital. So you don't need to have large facility for simulation. You could have the equipment, just move them wherever you need. And just-in-time education is a big area. You could just keep the simulation equipments till you have a patient that need LB in nursery, and you just practice LB on the mannequin before you do it in the patient. That's what we call just-in-time training. Disadvantages, participants can be taken away by pagers and phone because it's not dedicated time. Psychological safety, because when you debrief people, you will debrief them in public, so that will just decrease the amount of privacy they have. Sometimes you can't do all the fancy things that we do in the simulation center, like smoke. You can't introduce smoke machine in the workplace. It's very dangerous. You can't turn power failure or oxygen failure like what you do in simulation center, because that could affect other patients. So that's kind of disadvantage. And time and cost of setting up the equipments if you want to use elaborate setups. Of course, the faculty lack of experience. You might have some people getting into the debriefing and they're not very well expert in debriefing, and that you could work on by improving the faculty training. Difficult to implement technology as you would do, and potential use of simulated drugs in real patients, and cost of using real equipment. A lot of people say, oh, this is too expensive to use for simulation. For safety issues, I'll just show you one simulation that we did for rapid response team.
Sir, please, this is patient.
Who was recording the events of the CBR? Okay, hold CBR, please. Hold CBR, switch role, somebody else should come forward.
This is in our ER.
Everyone should be clear, please.
Clear.
Are we clear? Doctor,
Yellow light.
Doctor, please don't take much time. Continue back. Yes. Okay.
So, of course, it's another 3 minutes. Okay. So, of course, as you could see, once the simulation finished, there is some safety issues. What if you leave some of the drugs there from the simulation, expired, contaminated, mislabeled drugs, and you could use it later because you've run the simulation in the real place. So what if you leave some of the drugs? What about if you use simulated defibrillator, like what you see, and then you have a real case, and then they move the equipments and misuse in a patient. So that's also you need to pay attention. And of course, contamination of equipments, because we know that there is different standards. So when you move the simulation equipments from the simulation center to the clinical areas and move it back, what's the risk of contamination? You need to think of that. Of course, what if you use the real equipment and then you have another arrest in the ER? Where is the equipment? Do you keep it in the simulation or you move it to the real patients? Sometimes, and that's something that we keep in mind, what if the learners behave in a different way? They say, I would not compress hard because I'm afraid to break. I would do this in real life. So if you don't debrief this very carefully, people could learn bad mistakes from simulation, and then they take it to, because they say, oh, we've done it in simulation, they did not comment. So you need to pay attention, and these are some of the impacts. Of course, if there is families, there is all of a sudden, there is simulation, and there is crashing, and then people laughing. They might misinterpret this if it's not explained to everybody in the ER or the ward or the pediatric ward, oh, this was simulation training. It's really serious. They're laughing because now they're relieved, so you need to account for people that usually you don't account for in the simulation center. Of course, as I said, it's not one option. There are lots of options, like modified temporary in situ. So you could have a place that you could use behind the ER, permanent dedicated, like in the OR, you could just locate one of the ORs. Of course, the cost, realism, and the setup ease is different. A mobile, self-contained, a lot of places have a cart that's very much equipped with everything, especially in pediatric hospital. They have a cart like the drug trolleys, and they move it everywhere in the hospital. It has everything, the simulator, the recording, the debriefing equipment, everything in that cart. And that's a very good alteration to the insight to simulation. Of course, the most important thing, like we said yesterday, the objective. So you have to have general need assessment, problem identification, learner needs, goals, and objective. And then you have to develop your education or simulation activities, go through implementation and evaluation for the programmer learners, and go again like an iterative process. You have to make sure that learner needs are met with good implementation. You have to have goal and objectives, and that's evaluation. And you have to make sure that the need assessment and simulation is the right solution. So always keep in mind the goal of the simulation. So you need to have a good assessment, and then planning and re-evaluation and the logistics. So to summarize, I think simulation, insight to simulation is very important, complementary to other elements of simulation to improve patient safety. Careful planning is needed. A program-specific training set up to meet the goals, and it's a system integration. It's a key to get your program effectively done, because there are a lot of resources. You have to assess, plan, train, and reassess as you go. Can't do this without the support of my great team at King Abdulaziz University Simulation Center, and thanks again.